It's going.
All right. Welcome. We'll get started here in about 1 minute. We'll get started in about a minute. If you have questions, please enter them in the Q&A. All right, well, why don't we go ahead and get started. My name is Mike Eisen. I'm one of our transplant infectious disease attendings, and as you all are aware, there's been a lot of change as it relates to COVID-19, and so we thought it would be helpful to have a webinar to help give you an update on the Delta variant, boosters, and some change in guidance. We have a great group of people representing the entire transplant center here at Northwestern. In addition to myself, we've got Joe Leventhal, who's a transplant surgeon, Sejal Tana, who's transplant ID, John Friedwald, a transplant nephrology, Daniela Ladner, transplant surgery, Dan Ganger, transplant hepatology, Juan Carlos Casedo, transplant surgery, Rade Tomic with transplant pulmonology, Kambiz Gaforian, transplant cardiology, Taylor Heald-Sargent, pediatric transplant infectious diseases, and Shelley Sandana, one of our lead transplant coordinators. Over the next about half hour or so, we're going to give you an update of information about COVID-19, and then talk specifically from the pediatric standpoint on what we need to be thinking about as it relates to kids. Then we'll turn it over to Shelley, who will talk through the most common questions that patients are calling us about, so that you have some answers up front. Then we'll turn it over to the entire team to answer some of the questions that you put in to the Q&A. And I would encourage everyone to start putting the questions in as they come up in your minds, or if you have questions before you even get through the presentation. So I think the first thing is let's get an update of where we are in terms of COVID-19. Unfortunately, the rates of COVID-19 globally have gone up, and this is important if you're thinking about any travel to think about where the rate of COVID-19 is in your area. Since most of us are restricted to travel here in the United States, I thought it would be important to really give this updated map, which is updated today, looking at where there's significant COVID-19. The darker the red, the more COVID-19 cases there are. And so you can see really the Southeast is the epicenter of COVID-19 currently, although some of the Western states, particularly Oregon, Wyoming, and parts of Northern California and Eastern Washington have pretty high rates of COVID-19 currently. And these rates are having a significant impact on hospital utilization, with ICU beds near capacity at much of the states in the South. And you can look, compared to even earlier this year when we were going through our winter peak, the rates of ICU utilization are higher than they were before. The other thing that I think we need to keep in mind is where we are in terms of vaccines. The higher the rate of vaccine, the likelihood that we're going to see a slightly reduced impact from this current wave of COVID-19. As you can see, many of those areas that had very high rates of COVID-19 in the South are the same areas that have relatively low rates of vaccine uptake, whereas the Northeast, West Coast, and even the upper Midwest is doing much better in terms of vaccination. Focusing in on Illinois, you can see vaccine uptake is much greater in the northern parts of the state, particularly in the Chicagoland area. And we're seeing lower rates of COVID-19 than in the western part and southern half of the state, which both have lower rates of vaccination and higher rates of COVID-19. In terms of where we are in terms of new cases, we're seeing a rise in clinical cases throughout the entire state. The current case positivity rate per day is higher than it was during our first wave of COVID-19, and the little bump that we had when the UK variant came into the area. Still well below what we saw at the peak during the winter, but it's still uptrending, unfortunately. Hospitalizations got really low in the middle of the summer, but as you can see, we are coming back up with levels that were about where they were last summer and earlier in the spring. Thankfully, deaths nationwide and here in Illinois are remaining lower than before, and this is in part thanks to the vaccine. Let's talk now a little bit about variants, and this is just a visual graphic of all the variants that have been described due to in COVID-19. And while we focused on one or two variants, earlier in the year it was that blue box, which was the UK variant, whereas the yellow variant down here in the one corner has grown substantially to be the Delta variant. It's important to recognize that there's a huge array of different virus variants that are out there. What will become the next major variant is something that time is going to have to tell us. But what we need to expect is that this virus, just like most other viruses, is going to continue to mature and change over time, and new variants may arise, and we may have to rethink our approach to this infection. All of us have been talking about the Delta variant. This is a graphical depiction of the Delta variant on the spike protein. The little red fork that you can see coming down from the virus is what the spike protein looks like, and the blue is the ACE2 receptor on the cell. There are two major mutations that have really transformed the virus with this mutation. The one is that the L452 mutation, which facilitates the spread of the virus. It facilitates the virus from being able to connect and twist so that the virus comes in quicker contact with the cell. And then the little mutation right down by where it's meeting to the ACE2 receptor has changed so that it really is allowing the virus to start to escape the antibodies to a partial degree. We've learned a lot about this variant over time, and the first is what we've learned in unvaccinated individuals. Unvaccinated individuals have about 1,000-fold higher amounts of virus in their nose than the prior types of COVID-19. This means that not only is there more virus there, that there's a possibility that the virus can be transmitted more readily. We've also learned that the virus starts growing much more quickly in the nose, so that patients become infectious about 12 to 24 hours sooner than with some of the other variants. These together, as well as other factors such as being less focused on things like social distancing and mask wearing, has resulted in a higher rate of patients getting vaccinated or getting infected with the Delta variant with every index patient. So for every individual that is infected with COVID-19 with the Delta variant, they can transmit that on to about 5 individuals, which is double what we were seeing with some of the other prior variants. Among vaccinated individuals, the good news is we're seeing milder symptoms with the breakthrough infections. In fact, many patients may have very limited to no symptoms at all. And when they do have those symptoms are much shorter in duration than in prior variants. Unfortunately, when people do get infected, the amount of virus in the nose of a vaccinated person is the same as a person that's unvaccinated, meaning that they have a very high amount of virus and therefore may be able to transmit the virus to other individuals. The good news is that the virus is cleared much more quickly from patients that have received the vaccine, even if they get a breakthrough infection. And this is why the risk of hospitalization and death is much lower in these individuals. I think the most important thing, though, to recognize is that the majority of breakthrough cases are being driven by people that are unvaccinated. For all comers with vaccine, only about 2% of individuals have gotten breakthrough infections. So that's an incredibly small proportion of patients. We've also learned that the severity of illness is markedly reduced in patients that have gotten vaccinated. They're 8 times less likely to get infected than an unvaccinated individual, 25 times less likely to be hospitalized, and 24 times less likely to die if they've been vaccinated compared to someone who isn't vaccinated. And in fact, if you look at the overall number of deaths in the United States due to COVID-19, less than 1% of the deaths are in vaccinated individuals. Almost all of the deaths that we're seeing are patients that haven't been vaccinated for COVID-19. And I think at this point, it's important to go back and think about how these vaccines work. Once you get the vaccine, basically you produce 2 different types of immune response. The first are antibodies. These are proteins in your blood that bind to the virus and prevent it from being able to infect you. And really, these are what's important from preventing you from getting sick in the first place when exposed to SARS-CoV-2, the virus that causes COVID-19. The vaccine also produces cellular responses, these T cells whose job is to fight off infected cells and clear them out very quickly. And these are what are responsible for patients that get an infection, in making them recover from the infection more quickly, not require hospitalization, and not die from the infection. These cells really turn on very quickly and really activate effectively in clearing the infection. What we've learned over time is that our transplant patients do generate a very good cellular response to these COVID vaccines, but after 2 doses of the vaccine, only about 40 to 50% of patients have detectable levels of antibodies to protect them from primary infection. This led to Dipali Kumar and her colleagues at the University of Toronto doing this randomized placebo-controlled study in which they looked at patients that had got 2 doses of COVID vaccine and were solid organ transplant patients, and randomized half the patients to get a 3rd dose and the other half to get a placebo or saline injection. What they found is that the proportion of patients that had a response to the vaccine increased substantially. So after the 3rd dose, about 55% of patients had antibody titers that were felt to be at a level that should help protect them from infection. In addition, it increased the proportion of patients that had those cellular responses, so that the majority of individuals after the 3rd dose had a good cellular response to protect them against severe disease. As a result of this study and some other studies that were done, the FDA amended the EUA for the Pfizer and Moderna vaccine to allow a 3rd dose of the vaccine in patients that are immunocompromised, including solid organ transplant patients. Because of a lack of data, this does not apply to the patients that got the Janssen or J&J vaccine for COVID-19. More data will probably come out in the near future with an update in the near future. The 3rd dose ideally should be the same vaccine type as you got the first time. So if you got Pfizer for the first 2 shots, ideally you should get the 3rd shot with Pfizer. If for whatever reason you just can't find that same vaccine, it's okay to get the alternative vaccine. The 3rd dose should be given at least 1 month after the 2nd dose. But if it's even further than 28 days, that's fine as well. What we have to recognize, though, is that even with the 3rd dose, there's a sizable proportion of patients that still don't have a significant antibody formation. And as a result, even if you get a 3rd dose of vaccine, it's critically important that you continue masking, social distancing, and minimizing high-risk exposures, even though you've gotten that vaccine. And you need to really calibrate your caution based on the rate of infection in your area or where you're going. If the rates are high or increasing, you have to be extra cautious and really be as cautious as you can, minimizing those exposures, wearing a mask, and staying socially distanced. Now, I think the important thing is there's been a lot of discussion and fear generated by these breakthrough infections. I think the critical thing is that there's data that's coming out. This is just one example coming from the group at the University of California at San Diego, which clearly shows that the number of infections that are breaking through in patients, solid organ transplant patients that are infected, is far lower than what is seen in unvaccinated transplant patients. And the risk of being hospitalized and dying of COVID-19 with the vaccine is substantially lower in patients that have gotten the vaccine. So while it's possible to have a breakthrough infection, most patients, even solid organ transplant patients, should recover from their infection. But it's important to keep in mind vaccine is only one piece of the puzzle. We need to keep doing all of the different things to keep ourselves safe. Just like Swiss cheese, the holes won't line up if you're using multiple slices of Swiss cheese. Wearing a mask, staying distanced, paying extra caution when case rates are high, and getting the COVID vaccine. Key recommendations for us to keep in mind is that the Delta variant is clearly more transmissible than prior variants, and so we all need to be extra diligent. Vaccines are incredibly effective at preventing infections, but when those breakthrough infections occur, they're very effective at reducing hospitalizations and deaths. Solid organ transplant patients should obtain a third dose of the mRNA. If you've gotten the J&J at this point, we're going to have to wait until we get additional information. It's easiest to get the vaccine at your local pharmacy, but I would call ahead or look online to make sure that they have the vaccine type that you're looking for. Ideally, you should get the same type of vaccine as you got for the primary series. If for whatever reason you can't get access to that, it's okay to switch brands. You don't need documentation or approval from the transplant team. You can just go to the pharmacy directly. If you had a recent rejection or a recent transplant, it's important to talk to the transplant team about when you should go for the third dose of the vaccine. And we still are not recommending any antibody testing before or after the vaccine. It's incredibly important that you continue to wear your mask, continually social distancing, and avoid high-risk settings, particularly even if you've gotten the third dose of vaccine. And then, God forbid you get sick, call the transplant team immediately. There are therapies that we have, like the monoclonal antibodies, which we can give to you and help further reduce your risk of hospitalization. So now I'm going to turn it over to our Taylor, who will talk to us a little bit about pediatric issues. There you go, Taylor. We can't hear you.
You need to unmute there, Taylor.
Seems that microphone is muted.
Taylor, we still can't hear you.
I'm trying to unmute.
There we go.
Okay.
Yep.
Wonderful. Sorry, my computer is very delayed in Teams, and so it isn't responding as quickly as I would hoped. Anyway, I'm Dr. Heald-Sargent with Pediatric Infectious Disease over at Lurie Children's Hospital, specifically the Transplant Infectious Disease Service. And today I wanted to bring you an update on some information that we've learned about pediatrics and COVID-19. Although it seems like we're in a very similar scenario and place that we were a year ago with school starting, we actually have learned a lot in the last year. And for those of you with children entering school and you're transplant recipients, or you have children who are transplant recipients, I'm hoping that you can get some information out of here that'll help you. So first, about transmission. As was suspected, it's definitely been confirmed that children can transmit SARS coronavirus type 2 to others. And a recent paper actually indicated that young children less than 3 years old might be able to transmit even more than adolescents when they are the index case, so the first case that brings the coronavirus into their household. That's a very recent paper. It's not quite clear how that happens. There's some hypotheses such that they have higher loads, or just behavioral factors like kids spread everything to their parents if you've ever had one around. But not every kid is symptomatic. In fact, many are asymptomatic, and if they do have symptoms of coronavirus infection, it's very mild, such as just a cough or a fever, so it can be hard to tell if they do have an infection at all. So that's why we have to be vigilant if they've had exposures and following quarantine procedures. Now, from schools, we have learned a few things about transmissions in schools from looking at outbreak scenarios over the past year. And outbreaks have been rare, but they have happened, especially when there's been high rates of community transmission and the institutions, the schools have not been following all of the recommendations that were made, especially masking. Many studies have shown that when community rates are low, there's lower risk of spread, and that when they were wearing masks, they were even further protected. And the interesting thing about some of the outbreaks, which is the one depicted here, is that it seems that adults were often the case that started the issue, that the adults transmitted to the children rather than children to children spread. Now, the big caveat to this is there were still a lot of measures in place for the past year in schools, such as hybrid learning and remote learning, that could have mitigated some of these factors. And we'll have to see going into the next school year with more children in place what happens. But we have hoped that there's going to be less transmission. Okay, let's see if I can get to the next slide, since my mouse doesn't seem to like to use this. Oh, I skipped one slide. Oh, thank you. So for kids in school, the data is very clear, despite what you might be seeing on some of the angry outbursts at local school boards. Masking works. Masking is our best line of defense in school, and everyone over age 2 should be wearing a mask to help prevent and spread of infection. Physical distancing, the data is a little bit less clear, but what has been shown is that 6 feet is not a magic number. When there have been instances of spread, it hasn't necessarily been related to being less than 6 feet or over 6 feet. In fact, one study that was really nicely done showed that 3 feet was fine. So really just distance as you can, and hopefully at least 3 feet. Screening is another tool that's been instituted at many schools to try to help prevent the spread and catch those asymptomatic infections. But one thing to keep in mind is that no test is perfect, and you're always going to have instances where you might miss an asymptomatic patient because maybe the test wasn't robust enough, or you might say that somebody was infected when they really weren't, and that could lead to unnecessary quarantines. That's more likely to happen when you have low rates of community transmission, so low real infection amounts, but you can increased rate of false positives. Another thing that's come out is that there is an increased risk from sports and other activities, especially indoor sports and close contact sports. That makes sense because you have less ventilation and you're in more close contact. Again, these are things I'm sure you guys have all understood just inherently after living in the pandemic for the past year, but the data bears it. Someone could go to the next slide. Not sure if I have control or not. So if you have a child with a solid organ transplant, there are guidelines that will hopefully be coming out soon, specifically from many of the organizations. But in general, our recommendations are going to be some of those that you probably can guess, that wear a mask as much as you can. And if you can't convince your school to mandate masks, as would be recommended by the CDC and the American Academy of Pediatrics, at least ensure that your child is wearing a mask to try to protect themselves as much as possible. Of course, there are going to have to be considerations for individual children, especially because the risk of COVID-19 disease in children related to other comorbidities and their age. So take those factors into account. But overall, children, even with solid organ transplants, have been doing better than adults with in terms of clinical disease. And then you might want to consider asking for an individualized educational plan or a 504 plan through the school, which can help provide accommodations, such the case that your child has to be quarantined at home, or they need to have special accommodations to help distance them further from their classmates. And then, of course, recommend vaccination. So briefly, I wanted to give you an update on the pediatric vaccinations. So children over age 16, follow the guidance that Dr. Eisen talked about with all of the booster shots and the third doses. For 12 to 16, you can do that with the Pfizer vaccine. The Moderna vaccine has applied for emergency use authorization, but it hasn't been approved yet or authorized yet. The data for 6 to 11-year-olds is almost reaching the end and about to be submitted to the FDA. Hopefully, Pfizer has indicated by the end of September or maybe October that they will be able to apply for EUA, and hopefully Moderna shortly thereafter. We're waiting to see how long the FDA wants follow-up data, given the risk of myocarditis, although we're hoping that they'll shorten that period that they initially said was going to be 4 to 6 months to be a little shorter, since the cardiac side effects, if they're at risk, which have not been proven to be above baseline yet, they tend to occur earlier. So we're hoping that they will actually get the EUA a little bit earlier. And then the 6 months to 2 years trial is early in the earlier stages. It hasn't moved into the large population, so that's going to be even further. One thing I wanted to just mention on this slide, and I hope to leave with you guys, is I know there's been a discussion about why can't we just use the Pfizer approved vaccine now for children? We use other approved FDA products off-label for children, and I would not recommend that. Do not go out and have your children that are less than 12 dosed with the adult dose. Children's immune systems respond differently. That might be part of the reason why they're having more mild illness in general, and we don't want to give them unintended side effects because we give them too large a dose or the incorrect timing. We really need to wait for this data to come out on those trials and to use them appropriately. And with that, I'd like to turn it back to Dr. Eisen.
Great, thank you. So I think that was incredibly helpful. Let's see. I don't know how to get this back control from you. So we're going to move on to the next presentation, which is going to be from Shelley, who's going to talk to us a little bit about common questions that we get from our transplant patients and some answers for that. Shelley?
Hello, everyone. All right, I have a list of top questions that we have been getting from our patients. The first one is, do I need to call the transplant clinic before I get the booster shot? This one's no. You can go ahead and get the booster shot without calling us. Do I need a letter from the transplant center that I'm a transplant recipient? No. When should I get the third COVID vaccine? Now, or at least 28 days from the second COVID vaccine. Can I get the other vaccines around the same time as the COVID vaccine? It's recommended to wait at least 2 weeks before getting other vaccines in the COVID vaccine. Another question is, I just received my organ transplant last month. How long do I have to wait to receive the vaccine? We do recommend to wait 90 days from the transplant date to get the vaccine. Do I need to test for antibodies before or after the vaccine? The answer is no. I got the J&J vaccine. Can I get the booster? If you receive the J&J vaccine, a booster is not recommended at this time. Do I have to get the same brand as the first 2 vaccines I received? As Dr. Eisen mentioned, ideally you want to get the same brand as the first series, but if you are having trouble finding Pfizer or Moderna, you can go ahead and get the alternative vaccine. Where can I get the vaccine? That's the probably the most common question. Local pharmacies. Walgreens is doing walk-ins. We're hearing that Walmart's, you just call Walmart to set up an appointment. Costco, Osco, and CVS are also providing the booster shots. Northwestern at this time is not providing the booster shots, is from what we're hearing. What are the common symptoms we see in our transplant patients that get the booster? It sounds like it's the same as the first series, some arm soreness, headache, fatigue, mild fever that subsides in 24 hours with Tylenol. Another question is, my cousins who are unvaccinated want to come stay with me. Can they? We do not recommend they stay with you. Do I have to change anything with my medications or frequency of lab draws when I get the booster? No. What are the common symptoms we see from our transplant patients that do test positive for COVID? Unvaccinated, we're seeing more serious symptoms, shortness of breath, fever, which leads to inpatient hospital stays. With our vaccinated patients, more mild symptoms, so cough and mild fever and no shortness of breath. And the last question is, can I travel after I get the booster? No. We still are recommending to avoid non-essential travel at this time, continue masking, social distancing, avoid high-risk exposures, so including indoor dining, attending concerts, and being around those unvaccinated individuals. So still take extra caution with these increasing COVID cases. That is the top questions that we are receiving. I turn it back to Dr. Eisen.
Perfect. Well, I think that, and I will say that the frequently asked questions that Shelley just went through will be posted online, hopefully in the near future, as kind of an easy place to go for these common questions. So we've gotten a lot of great questions coming in, and I'm going to kind of send them to different people on our panel. The first question is going to be to Sejal Tana. So this is a patient that says, I was in the Hopkins study and have not responded to any of the vaccines. I've gotten 2 Pfizer and 2 Moderna vaccines and still don't have a response. What should I do?
Well, thank you for participating in the science. So I would really try to not focus so much on the antibody test results. It doesn't really give the whole picture of your immunity, like Dr. Eisen said. And we actually just don't know what level is actually protective. I think chasing the antibody level to try to get detectable is probably going to be futile. And instead, you should really make your decisions based on the amount of COVID in your community and the places that you're going to be. And most of all, really stick to the public health policies that we've been doing for the past 1.5 years, masking, social distancing, staying away from unvaccinated people.
Perfect. And the next question is going to go to Dr. Friedewald. This is a theme of a couple of questions, but I'm on mycophenolate and haven't had a good response. Should I stop taking the medicine?
I'm gonna make sure I'm unmuted. So good question. And the answer is no. I mean, I think as we step back and think about vaccines and how they work, obviously we are all very keenly aware of the fact that vaccines don't work as well in people who take immune suppression. And that's because the immune suppression is specifically designed to tamp down or blunt your immune response to the transplant. And the vaccines work in almost the same way that your immune response to the transplant works. I always say that we don't shut off your immune system completely because we need you to be able to fight off infections, but we do, like a thermostat, dial it down a bit. And so the response to any vaccine may be dialed down a bit as well. What we're seeing, though, from real world data, thankfully, is that the vaccines are providing protection, and that's really the most important part. What's really frustrating, and we all want to have a blood test that says, you know, I can go to Lollapalooza or not, or I can go to my aunt's house or not. And unfortunately, we don't know that yet. What the level of antibody that's protective, and we call that neutralizing antibody that can neutralize the virus. Importantly, also, Dr. Eisen mentioned there's one step where you can kill the virus before it gets to you. There's another step where your body can respond to the virus after you've been infected and keep the infection to a minimum. And that's what we're seeing. And a lot of people are having breakthrough infections. They're getting the infection, but the infection isn't as severe. I'm off topic from the original question, which is what about mycophenolate? And the answer is we want you to stay on your immune suppression. It's really important to protect your transplant, because if you form antibodies to your transplant, it's very hard to get rid of those. And we know that that can significantly shorten the life of your transplant. And so we're trying to prevent that. And right now it's frustrating, but I think Dr. Ison's Swiss cheese theory about, it's not the theory, the Swiss cheese picture about how multiple layers of protection are important. We all want to say, if I get the vaccine, I can stop masking, right? And the answer is no. Even me as an immunocompetent person still avoid certain situations that are high risk and still wear my mask. It's a multiple layers of protection that are going to keep us safest right now. And right now the fire is burning a little hotter, and so we all have to be a little more careful. So please stay on your medicine. Please call us if you're thinking about changing or stopping your medicine, because it can have real dangerous side effects for your transplant. And once you form those antibodies, the horse is out of the barn. It's hard to put them back in. And so right now, I know the data show that there are lower responses with drugs like mycophenolate. That's one of the reasons it works so well to keep your transplant healthy, unfortunately. So it's sort of the opposite problem. But for now, please don't stop your medicine. And if you're thinking about doing that, please call and have a conversation with us first.
So a related question for you, Dr. Ganger. This is from a liver patient. He said, I got the hepatitis B series after my transplant. I didn't respond to that. I'm worried that I didn't respond to the COVID vaccine. Are there any tests that I can get to see if I've had a response?
As you stated clearly, I don't think the antibody testing, in spite of being published and sending messages that you don't mount antibodies, we don't know the truth if they have or not response or cellular response. Until that becomes available, I think it could be possible that you do have antibodies that will protect you. So I wouldn't panic, but this is nothing new. Not everyone responds to a vaccine. The same for flu, the same for hepatitis B, but it doesn't mean that you would not respond to COVID. Sometimes there is a little difference and you may have mounted a response. So I wouldn't panic, but there is no antibody test that I would recommend.
Perfect. The next test I'm going to actually have two people answer. I'm going to have Dr. Tomic kind of give the adult perspective, and then Dr. Heald-Sargent talk about if it's an unvaccinated kid in the household. And so the question is, what to do if you are going to be indoors with others that you know are unvaccinated or can't keep yourself safe, like at a restaurant or something like that. Dr. Tomic? You're muted.
Just to oblige to all our recommendation regarding the safety in this context. So keep the distance, keep the mask on as much as you can, and we'll be safe as best as we can be. On the other side, we will recommend for everybody who is close to you, if it's adult, to get vaccinated. Strongly recommendation that everybody gets vaccinated, and that's probably the only way how to get out of the danger. Avoid the contact, avoid the visits from the family who are not vaccinated. Still strongly recommend that they are not staying with you if they are visiting Chicago, city where you are. And basically these are the kind of most important principles how to be safe in this type of circumstances.
Great. Taylor, what are your thoughts?
I appreciate you reminding everyone that children are unvaccinated, less than 12, and so you need to think of them as such. And just like Dr. Tomic said, try to keep their mask on, distanced, and really outdoors is best. Even children who haven't had solid organ transplants or who aren't at risk to spread it to parents who have immunocompromised conditions, they still should be avoiding being indoors maskless in general. Really, we all should be. So that includes restaurants where you have to take your mask off for a prolonged period of time. I know it's very long time that we've been dealing with this, but hopefully if we can continue to get everyone vaccinated, and that includes children, in the next year, fingers crossed, we'll be out of it soon, and we just need to keep everyone safe until that time.
Perfect. Next is going to be for Dr. Leventhal. My work is asking for me to come back to work. Is it safe for me to go back to my office?
Thanks, Mike. And that's it's not a straightforward answer. I think it has a lot to do with, well, certainly what the vaccination status is of the workplace that you're going to. In fact, with the approval, the official FDA approval of the Pfizer vaccine, I think we've all seen a number of large organizations move very quickly to make vaccination a condition of employment for individuals, or mandatory testing and strict masking for people coming into the workplace. So I think that that's something to factor in. Obviously, I think, again, the Swiss cheese model that we've talked about, controlling your environment, coming to work is one thing, but what you're doing in the workplace environment, staying masked if you're unclear about the vaccination status of your coworkers. But I do think that we'll be seeing an increasing number of employers now with the approval of the vaccine moving towards making this a mandatory condition of returning to work for employees.
Perfect. So I think the next question will be for Dr. Ladner. So I've gotten a booster. Does that mean I can start doing all the things that I want to do and not wear a mask?
No, unfortunately not, and it won't be like this for a while. Just to reiterate, actually, what all my colleagues said before, it is really important to use as many barriers against this virus as possible. And like Dr. Friedwald, I'd like to refer to the Swiss cheese model that Dr. Eisen showed. I think it really shows very clearly that one of these things, including vaccination or masking or distancing alone, is not effective. It's really important to do as many of these things all together at all times, and this is especially important for our immunocompromised patients. You are at higher risk, and so a booster is basically just improving your vaccination, your original vaccination, but nothing has changed in terms of behavior, what the suggestions are for you going forward.
Perfect. Thanks. Next is going to be for Dr. Tana. I'm really frustrated. I got the J&J, and now I'm told I can't get another vaccine. What should I be looking out for in the near future, and what can I do while I'm waiting?
Yeah, I think we're all frustrated waiting for guidance about the Johnson & Johnson. The FDA and the CDC are waiting to try to compile more data to make a strong recommendation. In the interim, it's really just hang tight, and I know that's really frustrating, but practicing all the social distancing measures, masking, surrounding yourself with vaccinated people is really the best thing that we can do while we wait for guidance from the appropriate authorities.
Perfect. A question for you, Dr. Friedwald. I'm a kidney patient. I've gotten a booster, but I'm still very nervous. We all know that people aren't masking as well as we would like, and there's no easy way to know who's infected around us. I'm terrified. What should I do to help keep myself safe?
Yeah, good question. And unfortunately, with the way Delta is going, we're all kind of feeling that way a little bit. Even those of us who have transplants and those that don't. Right now, the good news is we've learned a lot about this virus over the last 18 months. And one of the couple key things are things that Dr. Eisen had on that slide. But, the vaccine is really still very important because it is sort of like the last level of protection in terms of keeping us, if we get infected, from getting really sick. And, most of us are okay being home on the couch with the sniffles and a bad fever. And that's hopefully what the vaccine makes this virus, not the kind of thing that ends up in the ICU. Number one. Number two, we know masks really do work. We've been caring for patients in the hospital with COVID now for a long time, and most of us have not gotten infected, and though we spend long amounts of time with people coughing COVID all over us. So we know that masks and eye protection really do work to reduce infection. That is one of our best defenses. So your mask and a good mask. I saw a question earlier about, cloth masks. We also have learned that the better the mask, the lower chance of passing virus along. So the best are the N95s. Those are not terribly comfortable to wear for long periods of time. Those are very tight fitting and very restrictive, but they are the best. There are KN95 masks, which aren't quite as good, but good barriers, on down to surgical masks. And I think the lowest level are probably the cloth masks. And so there are data showing that if you combine a surgical mask with a cloth mask, that is better as well. And so thinking about what mask you're wearing is also important, and there's evidence out there about the different types of masks to further help you. But I've seen questions about when is this all going to end. I think the answer is that the more people that get vaccinated, the virus won't have a place to go. And so being a vaccine champion, we all do that here at work. If you do that in your community and with your family, that will help end this sooner. But as long as the virus has a place to keep going, replicating, it's going to keep mutating and varying, and that's going to keep us running from it. The questions about what vaccines are coming next, a fourth or a fifth dose, I think we'll probably see this, and again, we're learning as this goes, but we'll probably see, like the flu virus, that the vaccine may need to be updated periodically over time to keep up with the new variants that we're seeing. Luckily, there's a lot of work being done with this, a lot of research going into vaccines, a lot of resources. And so, thankfully, we've had a vaccine in a very short period of time, and that's helped protect a lot of us. And so that's the good news here.
So the next question will be for Shelley. I just got exposed to someone who I know has COVID-19. They called and told me. What should I do?
For known exposures, we definitely want you all to call our transplant clinic. We can go ahead and set you up for COVID testing. And then once we get the results for that, we can tell you to, quarantine. We can add you on a COVID watch list where you'll get a call almost every day from one of us here at the transplant clinic to just check up on you and make sure you're doing okay. But yes, if you have a known exposure, definitely give our transplant clinic a call and speak to one of the nurses, and we can guide you and see what we should do next.
Yeah. And then this is for Dr. Ganger. I've got an unvaccinated loved one who doesn't think the vaccine is needed and won't get it. He's taking some over-the-counter antivirals and that he thinks will protect him. Are these effective, or what should we do?
No, unfortunately, I wish we would have that easy of an answer to have antivirals. The current craziness about using an old drug for parasites is just going around, and it's actually, there's no science behind it. So you cannot rely on those. So it's a difficult situation, but the best thing she can do or he can do is keep the loved ones masked and at whatever safe distance that means. But it's kind of tragic that somebody who loves somebody else could give that somebody else a disease that could harm them. And this is, to me, beyond understanding. How could that happen? How cannot they cannot go and get vaccinated when the proof is so obvious? It's just, for us, it's kind of painful to hear when a patient says, I'm not going to get vaccinated, I don't believe on that. It's quite painful and it's very unfortunate.
Thanks. So the next question is going to go to Dr. Heald-Sargent. This is an adult question, but it relates to kids, and I think you addressed this a little bit in your talk, but I'm a teacher and I'm working around unvaccinated children and spending a lot of time indoors. Is that safe, and are there things that we can all do to be safer?
This is a tough one, and this is where it's really important that you make sure you're following as many of those layers in the Swiss cheese model as you can, starting with hopefully having all of your colleagues be vaccinated, because that's where we saw if there was transmission in the school, often it was between adults or adult to adult and not necessarily student to adult. or if it was student to adult, it was when they weren't wearing masks or they were very close contact, like one-on-one up in each other's faces. So just trying to make sure everyone, especially the adults that can, are vaccinated in your institution, advocating for that and advocating for mask requirements. I can't tell you it's 100% safe, but this is all about just decreasing the risk as much as possible and using the tools we have. And thankfully, in the last year, we've learned that those tools can be they're pretty good, especially masking and vaccination.
Cool. Another question for Dr. Friedwald. I'm on Valada Set. Anything that I need to know about with regard to the vaccine?
Yeah, good question. And there's not a ton of information about patients who are taking Valada Set and vaccine responsiveness. We do know that Valada Set is particularly effective at preventing antibody formation, which again is what it's designed to do. And let me just make a very important clarification from before. I mentioned antibodies. There's a difference between forming antibodies against the virus, which is what the vaccine tries to do, and forming antibodies against your kidney or your liver or your heart or whichever organ you've had transplanted. Those are very different things. Vaccine antibodies don't harm your transplant. They're very specific for the spike protein of the COVID virus. I'm just talking about if you lower your immune suppression and form antibodies against your transplant, that can be harmful. But there is a question about how to do this, and there isn't evidence to say what the best approach is. I think trying not to get the vaccine right around the time you have your Valada Set may be best, maybe a little bit before you get your infusion. Maybe the best evidence we can have now or the best device we can have now, but the quick answer is we don't know exactly.
Great, thanks. This will be a question for Dr. Tana. I'm a kidney transplant patient that got both doses of the Pfizer vaccine and unfortunately got COVID-19. I received monoclonal antibodies and I want to get my third dose. How long do I have to wait before I can get that dose?
Sure. The CDC is recommending waiting 90 days between the infusion of the monoclonal antibodies before you get a dose of the COVID vaccine.
Perfect. I don't know if Dr. Caicedo is on, but this might be a great one for him. There's a lot of people that are giving a lot of excuses for not getting a vaccine. They're afraid of dying from the vaccine or getting harmed by the vaccine. What can you say about that?
Yeah, first of all, I think there's a lot of misconceptions in the community, especially coming from the media, social media. I think that is dangerous because actually the vaccine saves lives, prevent getting sicker and requiring ICU, as has been mentioned, or dying. Then I think we have to trust the evidence, trust the science, and avoid to listen social media that sometimes is based on, no true data and no real evidence. Then I think we have to trust our system. Our science has progressed so much. In very short period of time, we're able to develop these very effective vaccines. And then I think that is the way to go, to be able to control this infection and save lives and to avoid more problems.
Perfect. Dr. Tomich, there's a lot of questions about which masks should we use. What are your recommendations?
I will kind of echo I think what Dr. Friedwald said. Probably the best one will be N95. And of course, it's a little bit harder to use for the prolonged period of time. Then the surgical mask will be the probably most tolerable and easier to wear, which will give us the best protection. Certainly will avoid what was recommended on the beginning of pandemic, scarves, cloth mask, and all of that whenever possible. So surgical mask will be probably easier to tolerate, and N95 is the best protection.
Perfect. Thank you so much. So the next question, and I'll send this to Dr. Ladner. I got my third dose of my vaccine because I'm a transplant patient. The rest of my family have gotten their vaccine. Should they get a third dose?
As for now, the recommendations are to really just follow the CDC recommendations. That includes immunocompromised patients. There might be, in short order, a third dose becoming available. And when it is available and recommended by the CDC, we strongly recommend that people around immunocompromised patients follow those guidelines and get a third dose. But as per today, that third dose is not available.
Cool. The next question is going to be for Dr. Tana. I've heard that there may be some home COVID tests. Are they any good? And should I think about using them?
So the home COVID tests tend to be more of an antigen rapid test, and they tend to be less sensitive than the PCR test that you would get here in Lavin or somewhere else that take a couple days to come back. I think it's a fair thing to do immediately if you have symptoms and you just want a quick answer. But if you got a negative result, I wouldn't trust it. If you have symptoms, I would go get that PCR test. And honestly, I would act like I have COVID if I have any sort of cold or allergy symptoms, no matter what any of the tests say. No test is perfect, but the rapid tests are definitely less sensitive than the PCR tests.
Perfect. So Dr. Leventhal, is it okay to be unmasked outside with a small group of friends without a mask, or should I be wearing a mask to be extra cautious?
I would recommend wearing a mask. You don't, certainly as an immunosuppressed transplant patient, you don't know necessarily what the vaccination status is of your friends. You're friends, but you don't necessarily know whether or not, sadly, what they're telling you is true. And so I think an ounce of prevention is worth a pound of cure. And so wearing a mask, I wear a mask whenever I'm out, regardless. And I think for patients, it's a wise thing to do as well.
Wonderful. So this is a question for Dr. Ganger. I'm really worried because the case numbers are up and I've got an appointment for my annual follow-up in a couple of weeks. Should I reschedule that to a later date when there's less COVID in the community?
No, I don't think they have to reschedule because we can, at this point, even though I think the hospital remains safe, we can always do a televisit if necessary. I prefer them not to postpone a visit, but have it on televisit. So do not cancel, just switch to televisit.
Perfect. And then we'll take one last question. That'll be a quick one. We've heard a lot about, and this will be for Dr. Tana, we've heard a lot about vaccines. What are the other options out there for people to help treat them if they get COVID, even if they've gotten the vaccine?
Yeah, so because of your transplant status, if you got COVID, you would still be at high risk for hospitalization. And so the biggest thing I would encourage you to do is to call us so we can try to set you up for monoclonal antibody infusion. It substantially reduces your risk of hospitalization and death, lowers your relative risk by 70%. We know that the sooner that we can get that into you, the better. So calling us as soon as you test positive is probably the most important thing.
Perfect. So I know some of you expressed frustration that we didn't get to your question. There were 116 questions that were there, so we didn't have time to get to every single question, but I do want to keep us to time. So again, just to remind you that even with 3 doses, transplant patients can still get COVID-19. So it's incredibly important to protect yourself with masks, washing your hands, and social distancing. If you got one of the mRNA vaccine, Moderna or Pfizer, you should get a 3rd dose of the vaccine. If you got the J&J, it's not recommended to get additional doses now. We'll communicate with you as guidance gets updated. Easiest to get it to your local pharmacy. Ideally, get the same vaccine as you've gotten before. You don't need any documentation or approval from the transplant team. And if you had a recent rejection or transplant, talk to the transplant team about when you should get the dosing. There's no antibody testing being recommended before or after the vaccine. And if you get sick, call the transplant team because we have things, including monoclonal antibodies, that can be given to you to help you get better faster and prevent you from getting in the hospital. And with that, I again just want to reiterate the vaccine is part of the protection, but it's all the other pieces, including masking. So be like the Art Institute lion, wear your mask at all times, stay safe, and thank you very much for taking time out to join us for tonight. Thank you.
Thanks, everybody.
Good night.
Thank you.